Assalamu alaikum. Thank you for the invitations. I'm glad to be here today, and I hope that we enjoy the talk on the ANCA vasculitis and the kidney. I know, like, when things it comes to the kidney, it sounds complicated, but I do promise that I will make it, like, easy for you. I don't know how it goes down. I'm poor in technology, so how can... طيب. We'll wait till it gets loaded. Okay. I have no affiliations to disclose to start with. Overall, kidney get hurt by ANCA vasculitis in 70 to 100% of the cases. To be more specific, usually kidney involvement occurs in 20 to 50% at the time of disease diagnosis, and in 70 to 80% during the disease course. Renal vasculitis can occur at any age, but it's most commonly seen in elderly and middle-aged and elderly patients. Why we do care about renal ANCA vasculitis? Because it has detrimental effect. Is everybody listening like my voice? لا أنا آسفة. Why we do care about the renal ANCA vasculitis? Because it has detrimental effect on the kidney and patient survival, as we'll explore this in the presentations. Because not all ANCA vasculitis are the same, so on the basis of clinical and pathologic features, renal ANCA vasculitis is subdivided clinically into granulomatosis cholangitis, or GPA, microscopic cholangitis, or MPA, or renal limited vasculitis. It's not that simple. We should further classify the disease based on the serotype into PR3, MBO, and negative ANCA. It sounds complicated, but it's considered that there are meaningful differences between patients who had PRA3-associated ANCA vasculitis and MBO-associated ANCA vasculitis, and it's been suggested that these diseases are they are distinct diseases that demonstrate different disease spectrum. Based on that, so in this talk, I will shed the light on the differences between GPA versus MPA, PR3 versus MBO when it comes to the kidney in terms of the disease clinical presentations, the treatment options, and the predictions of prognosis. Let's start with the clinical manifestations. Majority of patients with renal ANCA vasculitis, they have aggressive form of clinical presentations, usually in the form of rapidly progressive glomerulonephritis, or what we call it RPGN. RPGN is characterized clinically by the rapid decline in eGFR, at least like 50% from the baseline, usually over a short period of time, like from 3 days to 3 months, along with other features like microscopic hematuria with RBCs cast, subnephrotic range proteinuria, which means like proteinuria less than 1 gram if the presentation is acute. Or they might have like nephrotic range proteinuria, where the proteinuria is more than 3 grams if they have like acute and of chronic damage. Unfortunately, severe RPGN can cause dialysis dependence at the time diagnosis in 60% of the patients. Majority of the patients with RPGN, they have associated extrarenal manifestations. It can, renal ANCA vasculitis can also have a slowly progressive renal vasculitis form of presentations, where the patients, they have gradual decline in their GFR. That means they present with unexplained CKD, and the clues that they have like underlying glomerular disease, they will have also microscopic hematuria, with or without RBCs cast, and also a proteinuria. What are the characteristics of patients who have a slowly progressive disease? Usually they are elderly, they have MBA disease, they have the serologic type of P-ANCA or MBO-ANCA. Mostly they have renal limited disease, and like few of them, they have lung involvement, usually in the form subclinical interstitial lung disease, but none of them, they have like diffuse alveolar hemorrhage. Because of the slowly progressive disease and less extra renal manifestations, unfortunately, those patients, they get delayed diagnosis, sometimes up to 1 year. So that's why at the time of the diagnosis, they have lower eGFR, and they tend to progress to end-stage renal disease. Before we get the serology to confirm the diagnosis of the renal ANCA vasculitis, sometimes we have a clue clinically that might tell us that this patient has GPA or MPA. And GPA, it's most common in men. With GPA, they have like more ear, nose, throat involvement, and usually they tend to have higher PVAS score. While in MBA, usually patients, they are elderly. They tend to have higher baseline serum creatinine at the time of the diagnosis. Let's move to the diagnosis. Because RBGN is a serious condition that prompt immediate actions, as delaying diagnosis and the treatment will lead to chronic damage, and eventually patient might progress to end-stage kidney disease. So this notion directs us to the burning questions that we always face in a clinical practice whenever we are dealing with the suspected cases of renal ANCA vasculitis. Do we need to do a kidney biopsy, or we can start a treatment without kidney biopsy? Before we answer these questions, usually renal ANCA vasculitis it gets diagnosed by the integrations of serologic testing with the clinical presentations that usually provide the basis for doing kidney biopsy. So can we start treatment? I mean, like full treatment, induction therapy without kidney biopsy? The answer to these questions, it depends where you are practicing. If you have ELISA test, that's good, because ELISA, it outperforms the sensitivity and specificity of the indirect immunofluorescence. And if you have positive PR3 and c-ANCA, usually this antigen or antibody is associated with 93% specificity along with the clinical presentations. But the MPO and p-ANCA, they are less specific because it can't be positive in other inflammatory conditions other than vasculitis. So to summarize it, when we can delay the kidney biopsy and we can start the full induction therapy, if the patient has a clinical presentations that is compatible with ANCA vasculitis, if you have ELISA that is positive, that's strongly positive with PR3 or MPO ANCA, and you have like lower suspicions for other causes of secondary vasculitis, then you can postpone the kidney biopsy and you can initiate the treatment. But if the picture is vague, for example, the clinical presentation is not like fully compatible with the ANCA vasculitis, if you have ELISA test that is borderline positive or negative for PR3 or MPO ANCA, then you should wait, and you need to get the kidney biopsy. But like meanwhile, still you can start a steroid, because those patients, like the timing of initiating a treatment is very crucial in order not to develop the chronic damage, and then they can progress to end-stage renal disease. So it's safe to start a steroid, do kidney biopsy, and then after the kidney biopsy, you can proceed further with other treatment. Okay, we did the kidney biopsy. What we're going to find in the kidney biopsy, majority of patients with ANCA vasculitis, they will have a crescentic necrotizing GN, or just like a crescentic GN on light microscopy. On immunofluorescence, usually it's post-immune, and on electron microscopy, there is no immune complex deposits. Very few patients, they might have just interstitial vasculitis in the kidney biopsy, but I've never seen it, to be honest, in real practice. And unfortunately, very few patients also, they might have just with the pictures of chronic damage, diffuse global glomerulosclerosis and interstitial fibrosis. All ANCA subtypes, they are the same, like in terms of the active lesions. But what are the clues on the kidney biopsy that could differentiate between different ANCA subtypes? Usually in the term of how much the glomeruli is affected by the inflammations. Patient with GPA and PRA3 ANCA, they tend to have higher percentage of normal glomeruli compared to patients with MPA, renal-limited vasculitis, and MBO ANCA. Unfortunately, MPA and MBO ANCA, they tend to have higher percentage of glomerular sclerosis compared to GPA and PRA3. And that's like very important piece of information, as this, like we'll see later, how it will predict the kidney outcome later on. As we said, the active lesions, it's similar and like in all ANCA subtypes. So the crescentic lesions, it wasn't different between the different ANCA subtypes. The same things apply for the interstitial fibrosis and the tubular atrophy. MPA and MPO, they tend to have a higher percentage of interstitial fibrosis compared to GPA and PRA3. The same thing with the tubular atrophy. Okay. Let's move to the treatment. I'm not going to go into details. I will just focus on the part that is related to the kidney. So whenever we have a case of renal ANCA vasculitis, usually the usual induction therapy is steroid plus cyclophosphamide or rituximab. I will try to answer the questions. Do rituximab and cyclophosphamide have similar efficacy and safety profile when there is kidney involvement? And do we need to tailor the therapy based on the ANCA subtype or the severity of renal impairment? We have two landmark trials that tested the efficacy and safety of rituximab to cyclophosphamide, Rituxivas and RAVE. I won't go into details of these trials. I'll just focus on the kidney part. So in Rituxivas, it included a small number of patients with a newly diagnosed ANCA. All of them, they had renal involvement with median GFR of 20. Interesting in this study that the arm that they received rituximab, also they received 2 doses of cyclophosphamide. So it wasn't like a pure direct comparison of rituximab to cyclophosphamide. While in RAVE trial, it was like a bit larger trial that included both newly diagnosed and relapsing disease. 66% in this trial, patient had renal disease, and their mean GFR was higher compared to Pixivas. Their GFR was 50. And in this trial, it was like the arm that they received rituximab was not combined with other immunosuppressive therapy. So both the trials, they looked at the outcome of the primary endpoint of sustained remission, which was defined as absence of disease activity based on the BVAS score of 0. We can conclude from this trial that rituximab is non-inferior to cyclophosphamide for remission induction in patients with severe GPA and MPA, PRA3 and MPO with similar safety profile. Further analysis to the RAVE trial showed that rituximab could be superior to cyclophosphamide in patients who had severe relapsing disease at baseline. But both of these trials had short-term follow-up. It was only 6 months. This is an extended follow-up, a 12-month study that looked at the patient involved with the RAVE trial, and they looked specifically at renal outcome. So they looked at the renal remission, which was defined as stabilizations or improvement in serum creatinine and resolutions of hematuria. As we can see in this figure, the bottom line, patients who received rituximab, they started with a baseline GFR of 40, and over time, their GFR improved 49 at 18 months. The same thing happened with the patient who received cyclophosphamide. They started with a baseline GFR of 50. Over 18 months, their GFR improved to 57. In addition, they looked at the relapse. So in the rituximab arm, 6 patients had relapse, while only 2 in the cyclophosphamide. Only 2 patients in the cyclophosphamide group, they progressed to end-stage renal disease, but those patients, they had lower baseline creatinine at the time of the diagnosis. When they adjusted for the different ANCA type, for the disease, for the newly diagnosed versus relapsing disease, the results were consistent. So what we can conclude finally, that rituximab, yes, it has been shown comparable in efficacy and safety to cyclophosphamide for remission inductions in ANCA vasculitis. However, having said that, we do believe that general recommendations that rituximab should be used as first line in patients with severe ANCA vasculitis, including severe renal involvement, is not supported by the current evidence for the following flaws that present in the current evidence. RAVE and rituximab, both of them, they were not powered to determine the efficacy of rituximab on renal outcome. Moreover, none of them had pre-specified renal endpoint. Rituximab, which included patients with severe renal disease, rituximab was combined with 2 doses of cyclophosphamide, which might mask the true effect of rituximab. So when we have to use rituximab as first line, we suggest that rituximab can be used as first line in non-severe disease presentations in patients with PR3 or patients with relapsing disease. It depends on in the local resources where you are practicing, if you are having rituximab or not. Since we don't have robust evidence to inform which treatment is better over the other one, you have to share this with your patient, and then you can make shared positions after telling them about the pros and cons of each treatment. Let's move to another debatable questions. Do we need to do plasma exchange or PLEX for patients with renal ANCA vasculitis? We'll take it one by one. After numerous small trials that supported the efficacy of a PLEX in patients with severe renal ANCA vasculitis, MEPIX trial came that included a bit higher number of patients. It was 137 patients with biopsy-proven ANCA vasculitis. All patients in both arms received oral cyclophosphamide and prednisone. One arm randomized to PLEX and the other arm to IV methylprednisone. And the median serum creatinine, it was 700. And they looked at the primary endpoint of renal recovery at 3 months, which was defined by improved patient survival, dialysis independence, and serum creatinine less than 500. By 3 months, renal recovery had occurred, and 49% of patients who received IV methylprednisone, and in 69% of patients who received the plasma exchange. And further 12 months follow-up, the results were consistent and showed the benefit of PLEX in reducing the risk of end-stage kidney disease. A few years later, PIXI-VAS trial came and contradicted the result of the MEPIX trial. We'll figure out why they have contradicting results. So PIXI-VAS was larger trial compared to MEPIX. 75% of patients received cyclophosphamide and 15% rituximab. It was 2-factorial trial. I will talk just about the PLEX, not the steroid arm. So in one arm, patients they were randomized to either PLEX or no PLEX. In this trial, all patients, they had renal involvement, but the median serum creatinine was 300, which is lower the serum creatinine compared to MEPIX. Only 28% had serum creatinine more than 500. And they looked at the primary endpoint of a composite of death from any cause or developing end-stage kidney disease. As we can see in the figure, that the outcome were not different between patients who received the PLEX versus those who didn't receive PLEX. So we have 2 trials that have contradicting results. To make more information, we need to do systematic review and meta-analysis. So in this meta-analysis, they looked at the effective plasma exchange on end-stage kidney disease within 12 months follow-up in patients with ANCA-associated vasculitis. It included 7 RCTs. And in 6 RCTs, all of them, they had patients with severe renal impairment where median creatinine, it was like 500. The only trial that has lower serum creatinine was the PEXIVAS trial. So the final conclusions of this meta-analysis, they found that PLEX reduces the effect of, reduced the risk of end-stage kidney disease by 40% compared to those who did not have a PLEX. And the heterogeneity in this meta-analysis was low, so that's good. But on the other side, they found that the risk of serious infections increased by 20% in those who received the PLEX. However, the overall effect of a PLEX on the death was none. Okay, so we said that it reduces the risk of end-stage kidney disease by 40%, but this is relative risk, where they assume the patients they have similar risk factors. Then we have to get absolute risk reductions where it looks at each patient risk factors. So when they risk stratify the patients based on the score of the PVAS and the severity of renal impairment, the only positive result was that absolute reductions in end-stage kidney disease was significant with those with moderate to high risk. The risk was reduced by almost 5%, and those at high risk, 16%. So what we can conclude that PEXIVAS, it was larger trial, well-conducted trial, and 60% of the patient has serum creatinine less than 500. So we suggest that the PLEX not needed for those patients. For patients with serum creatinine more 500 and more, we suggest to consider PLEX. But since the evidence behind this is of low certainty, then we need to discuss it with the patients, the pros and cons of the PLEX, especially the risk of serious infections, and then let your patient share the decision with you. If I can, I have like 4 slides. Can I?
Doctora, we exceeded time. If you can conclude.
Okay. I was like about to talk about the prognosis, but like in summary, how can I go back? Okay, so renal ANCA vasculitis, usually they present with RPGN, but still there are a group of patients that they might present as CKD, especially in patients with MBA or MBO disease. Kidney biopsy can be delayed and the treatment commenced if clinical presentation is highly suggestive of renal ANCA and the ELISA test is strongly positive. In histopathology, all active lesions are the same, but GPA or PR3 tend to have more percentage of normal glomeruli, while MPA and MPO tend to have more chronic damage. Rituximab is non-inferior to cyclophosphamide in inducing remission in mild to moderate renal ANCA vasculitis, but in severe disease, robust evidence is lacking. PLEX has no impact on renal outcome in mild to moderate renal ANCA vasculitis, but reduced risk of end-stage renal disease and severe disease. However, benefit and risk need to be outweighed. Thank you.